A very good morning to all. The topic I've been given today is Surviving Sepsis Guidelines, and I'm going to talk in the context of the latest guidelines which were published in 2021. As you're all aware, sepsis is one of the most common admissions in the ICU, causes of admission in the ICU, but it's also one of the least understood. It accounts for almost 10% of admissions with a high mortality of 50%. The definitions of sepsis have evolved over the years. The first definition was given in 1991 by the American College of Chest Physicians and Society of Critical Care Medicine. And they defined sepsis as a systemic inflammatory response syndrome due to suspected or confirmed infection with two or more of the following criteria: temperature below 36 or above 38 degrees centigrade, heart rate greater than 90 per minute, respiratory rate more than 20 per minute or a PaCO2 less than 32 millimeters of mercury, and a TLC count of less than 4,000 or more than 12,000 or more than 10% bands. Severe sepsis was defined as a progression of sepsis to organ dysfunction, tissue hypoperfusion, or hypotension. And septic shock was when hypotension and organ dysfunction persisted despite volume resuscitation, thus necessitating the use of vasopressors. The definition was further refined in 2001, and some lab parameters were added. The sepsis definition remained the same, that is, presence of at least 2 SIRS criteria plus infection. Severe sepsis was sepsis with organ dysfunction, along with a serum lactate of more than 2 millimoles per liter. And septic shock was fluid-resistant hypotension requiring vasopressors or a lactate of at least 4 millimoles per liter. The Surviving Sepsis campaign adopted these guidelines in 2004 and further refined these guidelines in 2016 when severe sepsis was taken off, and sepsis is now defined as a life-threatening condition caused by a dysregulated host response to infection resulting in organ dysfunction. This means an increase in the SOFA score of 2 points or more. When it increases by 2 points or more, it means there's an organ dysfunction, and this is known as sepsis. Septic shock is a circulatory, cellular, and metabolic abnormality in these patients, which presents as fluid refractory hypotension requiring vasopressor therapy with associated tissue hypoperfusion and a lactate of more than 2 millimoles per liter. Now, the screening tools for sepsis include, in the previous definition, Q-SOFA was given a lot of importance, but in the present guidelines, they recommend against using Q-SOFA as a single tool for sepsis or septic shock because Q-SOFA is less sensitive as compared to SIRS, though it does alert to the possibility of sepsis and is validated for use outside the ICU. The other screening tools for sepsis include the SIRS criteria, which we've already talked about, the National Early Warning Score and the Modified Early Warning Score, and a lactate cutoff of about 2 millimoles per liter, which has prognostic significance and also correlates with mortality related to sepsis. In 2001, Rivers et al. Took out the early goal-directed therapy, in which certain physiological variables were maintained within certain limits. However, this goal-directed therapy is now obsolete, and the trend has gone in management away from a protocolized care in favor of appropriate usual care. This basically means a prompt recognition of sepsis, rapid implementation of appropriate antimicrobial therapy, and adequate fluid resuscitation. As you're all aware, sepsis and septic shock are medical emergencies, treatment and resuscitation of which should be done immediately. At the time of presentation of the patient in the emergency department, the R1 bundle should be implemented. The bundle includes measurement of lactate. This should be remeasured within 2 to 4 hours if the initial lactate was more than 2 millimoles per liter. Blood cultures are taken prior to starting antibiotics, at least 2 sets of cultures. Administer broad spectrum antibiotics. Rapid administration of 30 ml per kg of crystalloid for hypotension or a lactate of more than 4 millimoles per liter. And vasopressors are given if the patient is hypotensive to maintain a MAP of more than 65 millimeters of mercury. Now, fluid resuscitation remains the gold standard for critically ill patients in sepsis. 30 ml per kg of IV crystalloid fluid should be given within the first 3 hours of resuscitation. And that is because sepsis is associated with vasodilatation, capillary leak, thus leading to a decrease in the effective circulating blood volume and reducing the venous return. This impairs tissue perfusion and organ dysfunction. The goals of resuscitation include restoration of the intravascular volume, increase in the oxygen delivery to tissues, and reversal of organ dysfunction. Balanced crystalloids are preferred over isotonic solutions. Balanced crystalloids like ringalactate and plasmalite are associated with a lower incidence of renal injury, a lesser need for renal replacement therapy, and a lower mortality. On the other hand, isotonic saline is associated with hyperchloremic metabolic acidosis and renal vasoconstriction, increasing the chances of acute kidney injury. Now, the rationale for using colloids in any patient is to increase the intravascular oncotic pressure and reduce capillary leak, thus reducing the amount of fluid required for resuscitation. But in vivo studies have failed to demonstrate any benefit in patients with sepsis. The only colloid which is recommended is albumin, and that too, if a significant amount of colloid is required to restore the intravascular volume, then albumin can be given. Because giving albumin it increases the blood pressure and leads to a lower net fluid balance. Hydroxyethyl starch and gelatin are associated with a higher incidence of renal failure and a higher mortality and are not recommended. Now, how do we assess how much volume of fluid is to be given? The static variables like heart rate, systolic pressure, and CVP are poor indicators of fluid status, and their ability to predict response to a fluid challenge when the CVP is within a relatively normal range is limited. The dynamic variables, on the other hand, measure the cardiovascular parameters in real time. They are more accurate in predicting preload responsiveness and are associated with a lower mortality. Based on the dynamic variables, the patients can be divided into fluid responders who increase their stroke volume with fluid therapy, and non-responders in whom the stroke volume does not increase when we infuse fluids. And how to differentiate between that? We see the change in the cardiac output, which can be measured either directly using thermodilution or echocardiography, or indirectly by changes in the intrathoracic pressure, which are assessed during the inspiratory and expiratory cycle. Fluid responders are known, they have a pulse pressure variation and a stroke volume variation of more than 12 to 13%. The plethysmographic variability index is more than 14%, and the IVC distensibility index, which is measured on the ultrasound, is more than 18%. However, these pulse pressure variation, the IVC diameter, etc., have certain limitations. They are applicable for patients who are mechanically ventilated and are on deep sedation. So the limitations are on spontaneously breathing patients, those having arrhythmias, having an open chest or abdomen, and patients with ARDS who are given a low tidal volume ventilation. And in such patients, the passive leg raising test can be used. When a patient is put in a semi-recumbent position, following that, the trunk is lowered and the legs are raised. This leads to a reversible preload challenge of 300 ml. And the cardiac output is assessed both pre and post the passive leg raising test. And this test is useful in patients who are spontaneously breathing, those having ARDS, and those having cardiac arrhythmias. Excessive fluids are harmful to the patient because it may lead to pulmonary edema, organ edema, hypoxic respiratory failure. It prolongs the ICU stay and increases mortality. Therefore, the concept of ROSE has come. In rescue, 1 to 2 liters of fluid is given to reverse hypotension, to reverse hypoperfusion and hypotension. In the optimization and stabilization phase, fluids are given to maintain perfusion. and in the de-escalation phase, fluids are removed from the body either by using diuretics or by RRT therapy, renal therapy. Now, lactate is an important biomarker of tissue hypoxia and dysfunction and is a surrogate for tissue perfusion. Increased production of lactate is seen during sepsis due to tissue hypoxia, accelerated glycolysis, use of medications like epinephrine, and liver failure. A lactate-guided resuscitation has been significantly found to decrease mortality, and a resuscitation to a goal of lactate clearance of 10% is similar to an SCVO2 target of more than 70%. So lactate is a good guide to therapeutic response, an indicator of severity, and a prognostic tool for mortality. The alternative measures of organ perfusion are temperature of the extremities, skin mottling, a capillary refill time, and these are all validated, easily performed, non-invasive, and are reproducible signs of tissue perfusion. Another clinical sign which can be used as a guide for resuscitation is the mean arterial pressure, which is a major driver for venous return and cardiac output. The current panel recommends targeting a mean arterial pressure of 65 millimeters of mercury in the initial resuscitation of patients with septic shock who require vasopressors. Now coming to antimicrobial therapy. Early administration of appropriate antimicrobials is one of the most effective interventions to reduce mortality in patients with sepsis. Antibiotics should be given within the first hour of recognizing sepsis after obtaining the relevant cultures. Usually broad-spectrum antibiotics in an adequate dose and a loading dose are given. And this would depend on the site of infection, previous use of antibiotics, the local susceptibility patterns, and the risk factors for the patient. Now, timing of antibiotic is crucial in a patient. When shock is present and sepsis is either definite, probable, or possible, antimicrobials should be given immediately within the first hour of recognition. If the shock is absent, but sepsis is possible, in that case, we can wait to differentiate between infectious versus non-infectious cause and administer antibiotic definitely within 3 hours if concern for infection still persists. Mortality increases by 7% for every hour that we do not give antibiotics in a patient with septic shock. A combination empirical therapy should be started in patients with septic shock, those having multi-drug resistant organisms, and in neutropenic patients. But once the causative pathogen and susceptibilities are known, we should narrow it down to a single negative coverage. Procalcitonin is undetectable in healthy states, but rises rapidly in response to pro-inflammatory stimuli, especially bacterial infections. Despite that, there is no role of procalcitonin for starting antimicrobials in sepsis and septic shock. De-escalation of antibiotics is very important because prolonged use is associated with an antimicrobial resistance, Clostridium difficile infection, and it increases mortality. So we should rapidly de-escalate, and this should be an essential component of our daily rounds. We should normally restrict antimicrobial therapy to the shortest course of 5 to 7 days, except in certain cases, like if the source control is not achieved, or in an immunocompromised host or endocarditis. Now here in de-escalation therapy, procalcitonin has a role, and a procalcitonin of less than 0.5 and a clinical evaluation are valuable guides to discontinue antibiotics. Early source control is imperative to achieve within 6 to 12 hours of diagnosis after initial resuscitation. This may include removal of infected intravascular devices, drainage of an abscess, debridement of an infected wound, or a surgical intervention. Inadequate source control may lead to worsening organ function and hemodynamic instability despite appropriate resuscitative measures. Now, many times, despite fluid resuscitation, hypotension and tissue hypoperfusion persists. What are the causes? The causes may be loss of normal sympathetic vascular tone, myocardial depression, microcirculatory dysregulation, and mitochondrial dysfunction. In such cases, vasopressors and inotropes restore oxygen delivery to the tissues by increasing the arterial pressure and cardiac output respectively. Norepinephrine is the first-line vasopressor, and it leads to vasoconstriction and increases the MAP with a minimal effect on heart rate. Vasopressin should be started when the norepinephrine doses exceed 0.25 to 0.5 microgram per kg per minute. Vasopressin is given in a fixed dose of 0.03 units per minute, as higher doses are associated with cardiac, digital, and splanchnic ischemia. Epinephrine is sometimes added when a combination of norepinephrine and vasopressin is not working to maintain a MAP of 65 millimeters of mercury. So use norepinephrine as a first-line vasopressor, targeting a MAP of 65 millimeters of mercury. If the MAP is inadequate, consider adding vasopressin. And if that is still inadequate, consider adding epinephrine. If norepinephrine is unavailable, either dopamine or epinephrine can be used with special attention to the risk of arrhythmias. Now, what is the role of inotropes? Sepsis-induced myocardial dysfunction is a major contributor to hemodynamic instability. This is manifested as a low cardiac output and elevated cardiac filling pressures. In such patients, we need to add dobutamine to norepinephrine or use epinephrine alone. Dobutamine increases the cardiac output and oxygen transport, also leading to a decrease in MAP and causing some tachycardia. Comparison of epinephrine and dobutamine shows no difference in mortality or any side effects. The response can be checked by looking at the cardiac output, the mixed venous oxygen saturation, and other indices of tissue perfusion. Levosimendan is no longer recommended. Invasive monitoring of blood pressure is preferred over non-invasive monitoring. Arterial catheter permits a safe, reliable, and continuous measurement of arterial pressure and allows a real-time analysis. Sometimes we may need to administer vasopressors peripherally to restore the MAP when a CVP line is not yet established. We can use it for 6 hours or so, and it should be given in a vein proximal to the antecubital fossa. We can have sepsis-induced hypoxemic respiratory failure, for which we need to give high concentration of inhaled oxygen with nasal prongs, face mask, or a venti mask. HFNC may be preferred to NIV, and if that also doesn't work, then many times we need to resort to invasive ventilation. In patients with sepsis-induced ARDS, we need to use lung protective strategies. In such patients, we should target a low tidal volume of 6 ml per kg to decrease the incidence of volume-induced lung injury. The goal for Plato pressure is less than 30 centimeters of water. The driving pressure, which is the difference between Plato pressure and the PEEP, should be kept below 12 to 15 centimeters of water. In patients with moderate to severe PEEP, moderate to severe ARDS, a higher PEEP is preferred to open the lung units and increase the oxygen with the PaO2. Prone position is recommended in such patients for maybe more than 12 hours daily when the PF ratio is less than 200. In severe ARDS, a venous ECMO is given when conventional mechanical ventilation fails. And in such patients, it's always better to use a conservative fluid strategy. Sedation should be minimized in mechanically ventilated sepsis patients, targeting specific titration endpoints. And intermittent sedation is preferred to a continuous one. One can do a daily sedation interruption. Primary use of opioids should be done, avoiding sedatives like benzodiazepines, and this leads to a decrease in the hospital stay, mechanical ventilation, and mortality. The role of corticosteroids, they are given in septic shock and ongoing requirement for vasopressor therapy. They lead to shock resolution and increased vasopressor-free days. The dose of norepinephrine or epinephrine, when it increases to 0.25 microgram per kg per minute for at least 4 hours, in these cases, a steroid is added. 200 milligram per day IV continuous infusion of F-colin or 50 milligram bolus 4 times a day for at least 3 days. It should be stopped once the vasopressors are stopped. Coming to blood products, we normally go with a restrictive transfusion strategy. Blood products, RBC is transfused only when the hemoglobin is less than 7, unless the patient has myocardial ischemia, severe hypoxemia, or acute hemorrhage. FFP is given to correct clotting abnormalities only if there is bleeding or there is an invasive procedure which is planned. Prophylactic platelet transfusion is recommended when the platelets are less than 10,000 in the absence of apparent bleeding, less than 20,000 if the patient has a significant risk of bleeding, and more than 50,000 is desirable if the patient is actively bleeding or has to go in for any surgery or an invasive procedure. Stress ulcer prophylaxis is always given as it decreases the incidence of GI hemorrhage, as patients in the ICU are very prone to it, though giving proton pump inhibitors does increase the risk of recurrent Clostridium difficile infection. Now, patients in the ICU, as you know, are very prone to a venous thromboembolism. The risk for DVT and pulmonary embolism is high, and this is especially increased in patients with septic shock and after using vasopressors. A low molecular weight heparin is preferred to an unfractionated heparin as it decreases the incidence of pulmonary embolism, heparin-induced thrombocytopenia, in addition to being easy to administer. In patients in whom pharmacologic thromboprophylaxis is contraindicated, they can go in for a mechanical thromboprophylaxis in terms of an intermittent pneumatic compression or graduated compression stockings. The combination of pharmacologic and mechanical prophylaxis is not recommended in the current guidelines. Continuous renal replacement therapy or intermittent hemodialysis should be given in patients with sepsis along with acute kidney injury. Renal replacement therapy should be given only for definitive indications like uremic complications, refractory acidemia, refractory fluid overload, or hyperkalemia. It should not be given just for an increase in the creatinine or oliguria. Glucose control is very important. Hyperglycemia more than 180 mg/%, hypoglycemia and increased glycemic variability are all associated with increased mortality. So initiation of insulin therapy should be done for persistent hyperglycemia when it's more than 180 mg/%, targeting a glucose range of 140 to 180 mg/%. Monitoring should be done frequently initially to keep the glucose values and the insulin infusion rates. When they become stable, we can increase the duration of monitoring. The indication of soda bicarb is severe metabolic acidosis at a pH of less than 7.2 and when there is acute kidney injury. In adult patients with septic shock and hypoperfusion-induced lactic acidemia, sodium bicarbonate is no longer recommended to improve hemodynamics or to reduce vasopressor requirements. Coming to nutrition, early enteral nutrition is always recommended in such patients as long as they can be fed enterally in less than 72 hours it's normally started. The advantages are maintenance of gut integrity, prevention of intestinal permeability, dampening of the inflammatory response, and it prevents the translocation of bacteria. But in patients when early enteral nutrition is not feasible, initiate intravenous glucose and advance the enteral feeds as tolerated over the first 7 days. Current evidence does not support starting early parenteral nutrition in the first 7 days unless the patient is malnourished, and feeds are generally withheld in patients with high vasopressor requirement. Now coming to the last, setting goals of care. These patients are very sick. Some of them are not going to make it. They have a high mortality. So we must discuss the goals of care and prognosticate the patient and their families early on. Many of these patients may be going home with a tracheostomy tube, a Foley's catheter, or a Ryle's tube. So it's important to integrate the principles of palliative care early into the treatment plan, thus reducing the suffering to the patient and their families. And a referral to a peer support group can also be suggested to such patients. So to conclude, sepsis is a life-threatening organ dysfunction that results from the body's response to infection. The trend in management favors an appropriate usual care. The key to management is prompt recognition of sepsis, appropriate antibiotics, careful hemodynamic support, and control of the source of infection. These will go a long way in decreasing the mortality in such patients. Thank you for your time.
Unmute, ma'am, please.
Yeah, I've unmuted myself.
I'm sorry. Thank you, Dr. Vandana, for the very nice and consolidated talk on sepsis. I've already heard your talk on sepsis earlier also. And thank you so much. We have some questions in the chat box for you.
Yeah, sure.
First question is, ma'am, what should be intra blood glucose target and how to start insulin at which dose to control sugar if high, and which fluid and how much to be given if sugar level is low?
The insulin has to be started when the blood glucose is more than 180 milligram%, and the maintenance is it should be maintained between 140 to 180 milligram%. We should not target a very low range as was earlier suggested between 80 to 120, because it's more difficult if the patient goes into hypoglycemia. If the patient goes into hypoglycemia, then we need to give 25% dextrose 100 ml, and then again you can recheck on the glucose. And if it's more than 80, then appropriately you have to dilute insulin 5% in this thing and start insulin therapy. Normally we divide it by 100 and then start it accordingly. So if it's 200 divided by 100, start it at 2 units of insulin per hour. And then you can check it out hourly, the blood glucose.
Okay. Then, we kindly repeat role of F-Corlin in patients on vasopressor.
F-Corlin should be started when your norepinephrine requirement has exceeded 0.25 microgram per kg per minute. It is normally given as a 200 milligram per day infusion, which is maybe difficult for us to give. So normally what we give is 50 milligram QID. It should be given for 3 days minimum, and it can be stopped. There is no need to taper it off. It can be stopped once we stop using vasopressors, both noradrenaline and vasopressin.
With this, I think there is one more question. What is that? Is there any role of calcium and thiamine in sepsis guidelines?
So in the current sepsis guidelines, there is no role of calcium and thiamine. They're quite clear about it. The studies have not shown any benefit. So there is no indication on starting them. It's all very empirical, and probably current research is ongoing, but the current guidelines do not suggest its use.
I think no more questions. So with this, I thank Dr. Vandana. Thank you for being there with us. And the next speaker.
Thank you very much, Dr. MD, for giving me this opportunity. It was a pleasure. Thanks a lot.
Next speaker is Dr. Kamalpreet Sodhi. She is, director and head critical care Deep Hospital, Ludhiana, and she is. There are so many things to her credit. She is ISCCM National Executive Committee member, editor of ISCCM Manual of RRT and ECMO, and lead author for ISCCM AKI and RRT guidelines, editor Critical Care Communications, board member College of Neurocritical Care, authored chapters in textbooks of medicine, critical care medicine. She has more than 30 publications in international and national index journals. Her areas of interest are nephrocritical care, obstetric critical care, infection control, ventilation, resuscitation, and sepsis. Her topic is mechanical ventilation